Hello, everyone, and thanks for tuning into the New Norm Town Hall, brought to you by Midway Education and Catapult Education. My name is Samantha Wendell, and I'll be moderating today's Town Hall. We have 4 expert panelists with us who will be answering pressing questions from the dental community. First off, we have Tracy Whale. She is the founder and president of Compliance Alliance, based out of Las Vegas, Nevada. She has been an RN for more than 3 decades. Tracy and her team have been working with doctors and dentists in private practice, developing OSHA and infection control programs since 1996. Next, we have Dr. Miles Cohn and Cornelia Cohn. Dr. Miles Cohn is a prosthodontist, a certified lab technician, international speaker, and owner of a private practice in Portland, Maine called Nuance Dental Specialist. He is also the editor-in-chief of the American College of Prosthodontics quarterly publication, The Messenger. And like I mentioned, Cornelia is with him today, and she is an international speaker, author, and is responsible for the office's practice management and day-to-day operations. Lastly, but not least, we've got Dr. Lou Graham, and he is the clinical director of Midway Education Center. He is also a global dental educator and is the founder of Catapult Group. Dr. Graham maintains a private practice in Chicago, Illinois. So to talk a little bit about the format for today, I'll be asking a series of questions that have been submitted prior to today's session. I'll be directing these specific questions to specific panelists based on their expertise. The panelists will have a total of 4 minutes to answer these questions, and I will be timing them. Questions submitted during the webinar in the questions box will be addressed at future town halls. You can also email your questions during or after the session to education@midwaydental.com. So let's begin with the first question. The first question is for Dr. Miles Cohn and Cornelia Cohn. The question is, do all states accept teledentistry? Which ones do or don't?
Okay. Thanks, Sam. So currently, to the best of our knowledge, now please understand that these guidelines and state legislature is changing very fast every day. But as we understand it now, there are 48 states of the 50 that do accept teledentistry, that allow dentists to practice teledentistry. The 2 that don't, and again, if somebody is watching this in one of these states and has any updated guidelines, please let us know. I'd be happy to find out. But per the last time that we checked, Texas is one state that does not. Texas currently does not allow teledentistry. And right here in New England, Connecticut does not currently allow it. However, it is on the Connecticut State Board to pass that. That's on their bill to get that pushed through. So they are working on that. I don't know if Texas is working on it at all. And that's as far as I know. And then everywhere else, it's good to go.
Thank you very much for that. We've got about 2.5 minutes left. Anybody have additional thoughts on that?
So Miles, let me ask you a question. If a state doesn't allow it, okay, so let's say Texas and Kentucky don't allow it, do they not allow you using teledentistry, or do they not allow you billing teledentistry?
So that's a good question, Lou. And to be honest, I'm not certain, right? Because I'm not in Texas, so I don't quite know how that works. Right. So in our own state of Maine, they only just recently passed the bill to allow teledentistry in Maine. Maine was actually one of the last states to come on board with this, which was a little ironic because we were giving webinars on it, right? So, and in Maine, Cornelia, how did that work?
Yeah, so I think it's about whether it falls within your state of your scope of practice. So if your board says that you're allowed to practice teledentistry, it means that falls within your state of your scope of practice, and then you are good to do that. a lot of the insurance carriers are already accepting that. So the billing is not a question. Yeah, it's just whether you can use it in that state, whether it falls within your scope of practice.
And the thing is, too, a lot of folks, whether they know it or not, are already using teledentistry, right? If you're taking digital radiographs and storing those radiographs, and then sending them to another provider for either a consultation or for a referral, that is a form of that's what we call asynchronous teledentistry. You're doing that already in one form or another. Yeah.
Okay,
Excellent.
thanks.
Yeah, I like that. I was going to say, we're going to probably move on. I've got another minute here, but yeah, I was going to say, let's just move on to the next question. And this next question, thank you both for the expertise on that. The next question is for Tracy. So Tracy, this is a PPE question, OSHA question. You know, what are the requirements? This is the hot topic. What are the requirements for PPE requirements as of today? As of April 28th, 2020, if I were to open up my practice and start seeing patients, what are those requirements? The million-dollar question.
I'm telling you, it sure is. This stuff is changing like the wind blows. You know, there's a lot of voices speaking, be it between OSHA, CDC, NIOSH, who works between the two. As of last night, this morning, it is still the guideline that people are wearing gloves, gowns, eye protection, preferably face shields, and an N95 respirator. So those are the minimum requirements, even with an asymptomatic patient. So, but Lou and I talked on another program that you can't just purchase N95 respirators and start wearing them. There are physicals required and testing before they ever use them, and annual recertification and stuff like that. But I think that people, if they want to wear N95s, they're really going to have to do a lot of other stuff before you can just start wearing them.
Tracy, I was going to ask you, I saw an article about how it is a contradiction for women to wear makeup with N95s, KN95s. Is that true?
Well, the key point between N95 respirators and what level 2s, level 3s, because filtration wise, they're equivalent. In fact, filtration in your level 3, level 2 mask is actually a little higher. But N95 masks, you have to do a seal check where you put it on your face, and it forms a seal around your face. And if you wear a lot of makeup, it's definitely going to ruin it because it's stuck to your face. I mean, you cinch them up pretty tight. And so as much as it's not a contraindication, anything that will impair that seal with the N95 respirator needs to be eliminated if at all possible. Facial hair is one of those. Men with stubble, that kind of thing can definitely be problematic, and you can't have them with N95s because when you wear an N95, you do a seal check every time you wear them, and you put your mask over your face and you breathe out, and then your mask pops off at some point. So you always breathe through your mask and not around it.
Okay, thank you.
Mm-hmm.
We've got 1:45. Any additional comments on that? Yes, Lou.
So Tracy, I want to bring the real world into this because when you and I did our thing and you put your face mask on, it was great. Everybody loved it. Okay. But I go to work Friday. I don't have that evaluation yet. And I've got 3 patients I know I'm going to be using some aerosol on. Oh my God, taboo. Great screening. I know they're low risk. I'll do my antibody test. If I can't do that, am I wrong to still use the KNs or the N95s? I guess that's the $100 question.
Yeah, you're really not supposed to wear it because everybody's face is different. Some are wider, some are thinner, some noses are, bigger, smaller, whatever the case may be. And it's honestly between here and here that makes N95 fitting so difficult. I will, when I fit test people, I may try 1, 2, 3, 4, 5 different masks on someone before I get one that fits adequately. Because if at any point, like people say, oh, these N95s are horrible because they fog my glasses. Well, that means that you're breathing around your mask, not through it. So you've got to get a good fit. Otherwise, they are no better than a regular mask because you're breathing around it.
And so wait, I got to ask you then. So if we're all so busy with all this new emergency dentistry, how do we get, what's the feasibility of getting Tracy's to fit test us? I mean, seriously.
Yeah, we are the busiest fit testers on the planet right now. We are so unbelievably busy sending my safety engineers out to do fit testing on people. You can buy the fit testing equipment, but your challenge with the fit testing equipment, number one, is getting it. And then, but when you get it, buy some bitter, buy some sweet. You can do this in your office on an ongoing basis, because as you have new hires, you're going to have to do it anyway. So 3M makes a great product that is the one you saw me in the other day. I can have someone bring me one. And they're tremendous. So was that 4 minutes? Was that what that beeper was?
Yeah. But you're on to something. I want you to finish
me a while.
finish your thought, and we'll move on to the next question.
Yeah, I mean, we're as busy as can be, but I'd start hunting for an N95 fit testing mask. I think the setup through 3M is a F like Foxtrot T Tango 30, I believe, is the one you need.
Okay.
We'll post that. We'll post that. Okay, Samantha? I think that'd be great for us to post for everybody.
I'll get you the exact numbers for that though.
Okay, we'll post that so everybody will have that. Thank you. All right, next question is for Lou. Will time and cost per patient increase due to disinfection protocols and more PPE?
Let's read this again. Will time and cost per patient, will time, and explain this one, reread this to me so I can understand this.
So I believe this question is meant, they're asking, so for example, hygiene patients, are they going to get, is there going to be more time based on the disinfection that we're going to have to do when turning around rooms? For example, if we're seating a crown, is more time going to go into that appointment because, again, of the disinfection, the amount of PPE that you have to put on? And then will costs go up as well? Are we going to start? I know that you've touched on this before, that we should increase our rates, but that is a frequently asked question is, will it go up?
Right. So I think Miles and I are going to answer this, so I'll put him on the spot too, because that's what I love to do. And Cornelia just gives him the look. Look, this is the reality. My hygienists work 4 10-hour days and see 1 patient an hour, okay? If the assistant walks in and turns over the room in what we'll call the Tracy guided era, it's going to take more time. The screening takes more time. The waiting room, it's going to be 1 person per, so everything's going to be rotating. Openly, we think we're a month out to probably even a little bit longer for hygiene because we want to pull in the Dentsply, PureVax, and other things. I think we'll be seeing fewer patients, absolutely charging for PPE, and I'm okay seeing fewer patients. And if it's 6 or 8 instead of 10 in hygiene, and my hygienists are doing what they want, I'm okay with that. Me personally, I know I'm going to go slower. I know I'm going to have more time to screen. I mean, walk them in and do everything, the pre-brushing, the pre-rinsing, all that. And they're not just sitting in my waiting room anymore so they can just walk in. So I know that we'll be adding more time. So my answer to everybody is, if this is you, as it is to me and Miles, and you're seeing PPO patients, this is going to be the time where you're going to start going, am I really going to continue to see discounted fees and discounted patients like this? So, because you won't really be able to afford it unless they really up their rates and pay the PPE fees that it's going to require. Miles, what's your thought?
Yeah, so that's a very good question, Lou. And our practice in Maine is a little unique, and it's a little different from many other practices, because in our office, it's just Cornelia and I. I don't have an assistant. I do all my own hygiene, right? And so we've always, because we're such a small office, we block off a lot of time between our patients already. And again, because we're out speaking a lot, we don't spend nearly as much time in our office as we do, like as somebody else would do, that's right down, another dentist that's right down the street. we've never really done that volume. And so we always like to think that we're, in our current position, we're a little bit ahead of the curve already, because we've already been doing the social distancing for 4 years now, you know. So maybe we're not the best model to base that off of. But to Lou's point, I will say, yeah, I think you have to charge for the PPE. Otherwise, I mean, this is a for-profit business that we're trying to run. I can't, I mean, that PPE it's not inexpensive, right? I mean, every time I do something, you know, that adds $10, $12 to the cost of business. Yeah, and it's time, right? So, and I think for most practitioners, like, time is the real commodity, right? So even for us, I do know that things will slow down a little bit. If we were only seeing, say, 3 or 4 patients a day, well, that might go down to 2 patients a day now, you know what I mean? Where we're spreading them out. And also consider our demographic. Maine has the oldest demographic in the entire country. I'm a prosthodontist. I'm not seeing a lot of 18-year-olds, right? The folks that I'm seeing are my mother's age or older, you know what I mean? My mother's mother. I mean, we're seeing folks we routinely see people that are in their mid 80s and 90s. So our patients are in that extremely high risk category, and a lot of our patients are themselves medical doctors and physicians. Like, they understand, hey, I should probably not come in, you know what I mean, if for no other reason. So there is going to be more gaps in between there. And so to make up for that, I suspect that folks will have to start charging a little bit more, but I think it's going to be a slippery slope, because if you're seeing fewer patients, you're charging more. Maybe these folks don't have nearly as much disposable income anymore. I don't know how that's going to work out. It'll be very interesting to see how this whole thing plays out.
Yeah, but I think what Lou was saying too is right on the money. You know, you're gonna fee-for-service practice is gonna make a lot more sense if you need to spread the patients so far apart, and you have that additional cost for the PPE. It's just it's going to be unfeasible to be able to be locked into those low prices dictated by the insurance companies. And that kind of business model is predicated upon volume, which is just not safe or feasible anymore.
So Samantha, let me just make one last point. This is when offices have to be thinking, how are they going to have their own in-office dental plans? How do they do financing with patients, with companies? And I'm not talking where you're taking 10 and 12% right off the top, because often that's unaffordable. So there are ways to practice fee-for-service, finance patients, and think this through versus taking 50% discounts from the big PPOs. That is utter insanity going forth in this crisis. Yeah.
You know, we are getting a lot of questions about I know we're over the 4-minute mark, but we are getting a lot of questions about a code established to help pay, help cover the increased PPE cost. You know, as insurance, are you going to start coding? We're going to start having a code for reimbursements.
There is a code. There is a code. I mean, we'll post it, but I know my front team, Sheila, who's missed billing, there is absolutely a code. And let me just also say, right now it's expensive, N95s, KN95s. If I'm going to order a custom Tracy mask from 3M, all those things add costs. If I'm buying a Novarest or air filtration, all that goes into a PPE cost. There's no way it's going to be $10 in my practice. It's just not feasible. If I break even, I'm okay with PPE costs. But initially, they're going to be higher. And that's just how it's going to be. When all these prices come down and there's more commodity available, then my PPE fees will come down. But you can't underprice the PPE code, because at breaking even, we can't discount our services even more. That's how I look at it. There is a fee, there is a code.
Okay, thank you. And we'll get that code and post it for the audience members that are interested in that. We will get the code and post it for you. All right, so let's move on, because we are, sorry, Lou, cutting you off. We're over that 4 minutes. And so we're going to move on to the next question. So we're going to come back to teledentistry. So I'm going to direct this to the Cones, to Cornelia and to Miles. The next question is, how sustainable do you feel teledentistry will be after this pandemic? Is this going to be the new norm?
Yeah, so I will kind of speak to that a little bit, and Miles, then maybe you can chime in as well. So I think there were a couple things that made teledentistry less widely adopted before this pandemic. One of the things were that people just weren't as inclined to use it, right? Like there was a little bit of a psychological barrier. And then also the HIPAA constraints, that was kind of a barrier as well. So what we have seen since 1994, when teledentistry first started getting implemented, and we speak in our webinar a little bit about that, how it started in the Army. So since then, steadily the technology has increased. And so now we're at that point where we have the technology, it's safe enough, but there were those couple barriers, right? The HIPAA and then the psychological thing. And what COVID-19 did for teledentistry is it kind of shifted everybody's mindset in terms of this. It kind of broke those barriers. So HIPAA has lifted some of those constraints, and so that is making it easier. And also people are just thinking differently about using teledentistry. People who otherwise would never have gone for it will be a lot more inclined now to do it. So we're looking at an environment where telehealth has really paved the way for us in dentistry in this. And I don't see how there is going to be any going back. So during COVID-19, if we really do a good job of rolling this out to our patients, showing them the benefit of this, like what Lou was saying, you know, what we were discussing about those PPE costs, this is fundamental. If we can get patients, if we can save them from coming into the practice, all of the time, the PPE costs associated with those unnecessary appointments, if you can triage them and we can do a lot of these things remotely and keep them out of the practice, this is huge, you know, like in terms of just convenience and cost. So I do really think that it is sustainable. And if you see how widely it's being adopted, all of these states now have some kind of policy in place and they're expanding upon it. Maine was lagging behind. Yeah. And during this pandemic, all of a sudden they came on board, pushed it through because everybody is starting to realize the value of this. So I don't think that there's any going back, and it is going to be sustainable over the long run. And there's going to be an increased adoption of payment and reimbursement, or otherwise, if you go the fee-for-service route, it really is a lot easier as well. Then you don't even really need to navigate all of that stuff too much.
Yeah, and I feel that teledentistry is going to be almost like another side branch of dentistry, just like endodontics or orthodontics or oral surgery or something like that is. And I think that once the process becomes more streamlined, which it is now with the billing, the coding, the platforms that are available now, the data encryption and the technology, once that starts becoming much easier to grasp for everybody, and once this process becomes profitable, right, for dentists, I think that there's going to be a big movement towards it. And like Cornelia said, I just don't think there's going to be any going back. Once people see the value that, hey, I don't need to go to the dentist all the time. I can be viewed right from my own home. And the dentists say, gosh, I don't need to wipe down the chair and get on don PPE anymore. I can just do a consultation from my break room, right? And I can still get paid for it. Why wouldn't you do that, right? And I think there's a huge amount of people that will really benefit from this. And just in telehealth alone, over the last like 15 years, I mean, there's been like a 20-fold increase in the number of people that require that service. And again, dentistry has always been sort of the redheaded stepchild to medicine. You know, we're moving along now, and it's unfortunate that it took something like COVID to give us a violent shove into that arena, but here we are. And I think, again, it's a testament to the fact of how popular this is becoming with all of the new platforms. I mean, everybody's got a platform now.
Every day.
Yeah, every day a new platform comes out, and I get spam in my inbox. Like I probably deleted 2 or 3 emails today about like, hey, check out this teledentistry platform. You know, it's just like delete. You know, just people cold calling me all the time because I looked up teledentistry once, so now I'm being like tracked. You know what I mean?
Yeah, and I guess that being said, I don't think that there's in some of the other webinars that we've done, afterwards we would get questions, and with things like Smile Direct Club, you know, like a lot of people are kind of scared that teledentistry is going to come and encroach on dentistry and it's going to maybe substitute it. I think the way to look at this is teledentistry is never going to replace dentistry. And I've said this before, dentistry is always to some extent going to be kind of a contact sport, right? Like, but we need to think about how we can use it as an effective tool to streamline our processes, get new patients into the practice, patients who have dental anxiety, you know, like just lower that barrier for them, roll additional care out to underserved communities. Like, there's all kinds of ways that we can use it that won't cannibalize our dental practice as we know it, but could really supplement it in a good way.
Okay. Well, thank you. We're at that 4-minute mark. That was really, really excellent information though. And, you know, my mind is thinking, well, why aren't we adapting this? I mean, we're working smarter, not harder. You know, I mean, it's a more efficient way to work. And we've already adapted technology when it comes to CE. So let's adapt technology when it comes to dentistry.
Exactly.
So very good points. So thank you for sharing your expertise. We are going to move on to another PPE question. This is geared towards Tracy. Tracy, if there's not enough PPE, can a hygienist and doctor and assistant wear the same gown all day? So I'm assuming, you know, people in your office seeing patients. What are your thoughts on that?
The gowns, not cloth, clinic jacket, lab coat type stuff. Those, the guideline for those is they should be taken off between every single patient and laundered. The pink blue gowns that people often wear, like surgical gowns, those have always been single use only. So they should never actually have been worn all day long. So all gowns should be removed following patient care for each patient. Probably the most cost-effective way to get through that then is laundry. You know, for those practices who built a washer dryer into their practice at some point, then if they're following CDC, because they're CDC guidelines for laundry, I think it's 160 degrees, 50 to 150 parts per million of bleach, and 160 degrees, so a really hot cycle. But the gown should be taken off between every single patient. And I have never been a fan of re-wearing masks between patients. My thing is, if you are not willing, if you've got a sleeve that's cuffed to here, if you are not, before you see your next patient, willing to lick your sleeve, you probably ought not be wearing that jacket. I'm pretty basic.
That's
very good point.
But it's true, you know, because if you think about it, you've got all this aerosol and it's all over your sleeves. And how many times do you fix your glove or fix your sleeve or scratch or whatever? And then, you know, there's never hand hygiene after that. So gowns are single use only and should be, regardless of whether or not they're cloth or whether or not they're disposable, they're all worn for one patient only and then thrown away at the end of the case.
Okay, thank you. You mean, well, we've got 2 minutes left, but I was going to ask, is there any way to sanitize that disposable gown? Because you know that we're going to try to be creative in reusing PPE here.
Absolutely, absolutely. Now there really isn't. In fact, there's some guidelines about reusing gowns, masks and stuff like that. But most of the supplies that are generally available in dentistry offices do not meet the criteria. They destroy the masks and make them less effective. And I haven't read anything about reusing gowns, you know, single-use only gowns.
All right, well, thank you. Does anybody have additional thoughts or comments on this?
Well, I'm just going to say, Tracy, not only do we agree, but this is where I think it's kind of crazy that these are governments, your governors, whatever, saying, oh yeah, let's just open up our offices. If we can't have enough PPE, then how are we supposed to protect the patient and protect ourselves? I mean, it's utterly ridiculous for me to think about reopening my practice in even 60% mode when I know universally we can't get enough PPE because the PPE is still going to primary caregivers. So I think the key point here is you got to use your common sense here. And this is why I just don't think we're ready to fully open. And I'm sorry, people think we are. There's not enough PPE right now to do that.
Yeah, it's a huge challenge. I needed more N95s for my team because they're going out and they're going into primary care facilities. And so I needed more N95s, and I called my guy and he said, I can maybe get you a box. Well, I need 3 different kinds of N95s because all my people have different size faces. So
Tracy, what are your thoughts about wearing the level 3 mask over the N95
Yeah,
and then
I've heard
reusing
that.
the N95? Because I think that might have even been on the ADA's webpage for their recommendations.
I know people.
yeah,
Yeah, and that's another question, but we can
we
definitely.
can wait. I can wait then. I'll wait till
No,
then.
do it now. Do it now.
I was gonna say, go ahead, we're on the topic. Miles asked it, let's talk about it, and we can
Oh,
just.
sorry, I didn't know that was a question.
Oh, no, you're good. You're good.
Well, I was the only one who got the dinger at 4 minutes. That's what I know.
I'm trying not to be too disruptive, but yeah,
That's okay.
keep going.
Now, in March, CDC came out with reuse of some personal protective equipment in regular mode, in we think we're running out mode, crisis we know we're going to run out mode. So there are provisions for wearing N95 respirators, and the guy who, when they did this webinar through CDC, included masks in that there is something called extended use. And extended use of a respirator says that I put my respirator on it with my eye protection at the beginning of the day, and I wear it all day long and never touch it and never take it off. Now you'll take it off at lunchtime when you sit down and, you know, have lunch or whatever, and you've got to, there's very specific techniques you use for doffing that equipment. And but you've got to be careful putting it on and taking it off, because people auto inoculate like mad. So the idea that you would, because there's also a provision to take it off and see cohorts of patients, but the more reasonable, the easier one to follow is extended use of respirators, where you put them on now and you do your seal check and you're done and you don't touch it anymore. And the other masks on top of them help to keep them dry, because I believe that your level 3s they provide a better fluid barrier than the N95s. And I use N95s generically, KN95s, it's just their country of origin, but they all meet the N95 standard. So that's kind of how that's the recommendation on that. And there's also a recommendation to reuse eye protection, some of the eye goggle type stuff, the Googles where they have a shield, some of those are disposable, and they're saying that you can re-clean those between patients, you know, with a intermediate level disinfectant, spray it, or wipe it and wipe it again. You always have to clean it before you can decontaminate it.
Thank you. Any additional thoughts on that, Dr. Graham or Dr. Cohn?
I agree. I think it's great.
Yeah.
Period. Move on.
Agreed. You know, I was laughing. My dad sent me an email about how he made his own mask. And he apparently, I mean, he's not in healthcare, but he's going to the grocery store and he's 80 years old. And I have to share this because he made this mask out of a bandana. And so my 80-year-old father is, you know, going in to the grocery store with his bandana mask on, and I just
Love it.
I can only help. I can't help myself. I have to laugh about it.
Yeah.
Let's move on to the next question and go a little bit into talking about people that are home right now. You know, they're off work, they're furloughed, but they're living with somebody or have a spouse that is actually an essential worker. So I'm going to direct this question to Lou. And the question is, what is the opinion about those of us who have been social distancing, you know, staying at home or furloughed, but their spouse or a different family member has still been working? You know, maybe they work at the grocery store, maybe they work at the ER. They're obviously at high risk. And the problem is that these are essential workers that are in the front lines, and they could be exposed to this virus without knowing, and could be passing it to us, especially those that are staying at home. So what are your thoughts about that? What's your opinion about that?
So, you know, you watch what emergency workers are doing, what emergency nurses are doing. They're living apart from their spouses. They are literally living in a different part of the house. and in isolation. That's what they're doing because they live in fear of cross-contaminating, because it's social, it's the intimate contact of living with someone is why so many people died in Italy. And it's that interaction that is the #1 cause of spread. Okay. So when you're doing a screening, I can't be any clearer than this. If my patient has not been out of the house, has only gone to the grocery store to mask, but her husband or his wife is an essential worker working at a senior facility home or a transit worker, they are immediately high risk just by associating with them day to day, unless those people are living apart. So my feeling is you just have to assume they're both high risk. That's it, unless they're really living independent lives. That's how I look at it.
Good point. What about those that, for example, what if like postal workers, they're not necessarily in direct contact with others like a nurse, but they are still out in the world being exposed. Is that a high risk job? Is that something?
You know, again, I think how I look at it, I err in caution. I don't know when that postal worker goes to their main office and are they all socially distancing and wearing masks? I don't know. So if I have any questions, I put them in the medium to high risk. A low risk patient has had no social interaction, or as a couple, they're just been in this together. So I think in your screening, you just have to go through the screening again, you know, and then you look at the prevalence in your community. In Chicago, it's high. In downstate Illinois, it could be low. So I think all of this comes into how you're going to screen. How do you want to handle your patients? I mean, I want to do antibody testing, and with all the stuff about antibody testing not being X, Y, and Z, it's still an additive screening protocol for me if I have any questions about my patients. And I want to keep myself safe and all my patients safe, and that's how I look at it. Yeah.
Yeah, sorry, can I just interject here? I'm just kind of wondering about the flip side of that thing. When we start seeing patients in our practice, you know, we might inevitably get exposed to it. There's definitely a higher risk of exposure for us. How, as dental professionals, how are you going to handle that then? Are you going to keep yourself a little bit distant, like when you get home as well? Like Miles and I have 4 small children at home.
You know, you ask honestly a critical question. I mean, you have people on social media dismissing this because the death rate is only 0.05 or 3%, yet we still have 55,000 people who passed away and all the comorbidities now if you have the virus. So you ask a really good question. And my feeling is that if we can truly minimize the risk, that's up to us. I mean, these ER workers and grocery store people, they're amongst, you know, hundreds and hundreds of people a day. We may be amongst 5 or 6 or 7 patients initially a day. So I think we can minimize our risk factors. And I think it's up to each practitioner how they want to then go home. I mean, we have a whole protocol of how we take off our clothes, where we're doing our laundry, everything. So I hear you. I mean, we're doing antibody testing of ourselves, and we're probably going to do antibody testing probably every other week. And we may do PCR testing too. I mean, I don't want to infect anybody, both in my home and any of my patients. So this is what I call the quasi question. I don't know, Cornelia. I just don't know.
That is a great question. Something I haven't thought about. You know,
But
being
I can,
on the front lines.
Can I interject here real quick?
Yes.
Pre-screening telephone triage is your best friend. That is going to be the key to success in your practice. You know, getting a temperature, preferably infrared from a distance on your patients before they come into your office, your hand hygiene, your oral rinses and stuff like that is going to be super important. But remember that patients shed the most virus when they are symptomatic. So if they come into your office and they're prodromal, they're a couple days pre-symptomatic type stuff, you get their temp is good, they look healthy, they feel healthy, and they come up positive later. Remember that they're shedding way less virus than they would be in the days subsequent to that. So telephone triage, temperature, stuff like that are going to be very, very important in your practice to limit this stuff.
And I would add, the next thing we're adding is, in a screening tool, is what's come out of Bellevue Hospital in the latest research is oxygen saturation. We all should be just putting on a pulse oximeter and measuring saturation, because what the emergency rooms are noting is asymptomatic patients have COVID and already potentially in that deep symptomatic stage have lower oxygen levels. So they don't know it. So I think in addition to temperature, I think we all got to, just doing an oxygen saturation reading just by putting it on their finger. It takes a matter of seconds to read your oxygen. And I would be adding that onto my protocols too in the office.
Yeah, that's what we've done.
Just so everybody know.
And just so everyone on the audience, just so you know, a lot of the resources that we are talking about in terms of the pre-screening questionnaire, that is posted on Midway education site. So midwayedu.com, you can find all of the resources to help your practice screen for these patients. I'm going to move on. Miles, you did touch a little bit on this. Same, Cornelia, you also touched on this, but if you could just elaborate a little bit more, how widely used is teledentistry in the US right now?
So I mean, it wasn't very widely used up until a few months ago. As of February 2020, a lot of people didn't even know what teledentistry was. If you mentioned it to them, they'd kind of like, oh, geez, I don't know. But now it's like one of these like buzzwords, what I mean? This is like a term that's gone viral now, and everybody's really interested in this. And so now I think, again, the fact that 48 of the 50 states have approved teledentistry procedures and so many insurance companies are now reimbursing for it, I think that it's pretty widespread. And again, we're still at the tip now. Again, as this moves on, it's going to become more and more and more. And I think as insurance companies see like the benefit of this, and as companies see the profit that can be made by people that want to like implement these platforms and the technology into their offices, I think it's just going to become one more tool, just like, like a Cavitron or, any sort of like a microscope or something like that. I think it's going to become increasing.
Yeah, I would agree
Yeah.
with that. Yeah.
Okay,
Yeah.
thank you.
Next
question.
Samantha, okay,
Yeah.
go.
No, you actually have 2 minutes and 54 seconds left. So
I don't need it. I'm just going to say, I think where teledentistry is going to be coming in even bigger is, and Cornelia really alluded to this, you drop an implant in or whatever, and routinely we have patients come back. You had a third molar removed or an extraction. You'll come back and do a post-op. I think we're going to do a lot of our post-ops teledentistry.
100%.
Yeah.
why not?
And I'm going to tell you, and this will be on the next show, I'm going to call it here the new norm. We're going to have a recall examination, and I'm not walking into the room. It's going to be a teledentistry recall exam. A hygienist giving me the information, and if there are any findings that we find together after the patient's left, I will then do a teledentistry meeting, tell the patient, this is what our findings are. Now we're going to schedule you. I am not walking in for a recall. I'm not putting on new PPE. I'm not doing that. I'm telling you, teledentistry is going to explode with new options. Cornelia we are just on the tip of this. There's no doubt about it.
Yeah. No, I 100% agree with what you're saying. And so that's like, yeah, that look-see appointment, like just let's see if everything looks fine. We can start eliminating that. And there is a long-standing, body of peer-reviewed literature that shows the efficacy of teledentistry. And this is even how it started, right? Like there's so much stuff that we can do that it's just as effective via teledentistry as it would be if we saw the patient there. There's no additional value that we can add with that inpatient appointment for some of these things, especially post-op stuff.
Yeah.
So I guess my question to add to this is, how would we do, Lou, could you dive a little bit deeper on how you would actually, how that would happen, what it would look like with a hygienist, you know, they finish with the cleaning, they're ready for the exam. How would you do the teledentistry? Would they use an intraoral camera? Would they use the smart mirror that we have talked about in the past? What are your thoughts on that?
Okay, so here's near term. Near term would be the hygienist, let's say, takes vertical bite wings. Let's say she's using Carry View or fluorescence, or we needed a cone beam instead of an FMX because I don't take FMXs anymore. All of that data will be compiled in addition to whether it's an annual probing. Then the hygienist will take, probably right now with all that we have, is an intraoral camera to highlight a few problem areas. That would then be then consulted with at lunchtime or at the end of the day, and then I would confer that information to the patient. Smart mirror is going to become ubiquitous, and I'll tell you why. When Smart Mirror comes out with their next launch, will be like a single, it'll be like one mirror per hygienist. The hygienist will be able to do a wraparound video of any areas and basically save it so the dentist now can look at it visually and see it. I just see us moving into, there will not be a traditional recall exam, I really think, for the next 18 to 24 months. And I think all these technologies will blend into what we'll be doing after work. Again, Tracy was the one who started me on this. You wear an N95 mask for 3 hours, I'm exhausted. You know, it's exhausting. I wish I was Miles's age, and I'm not. I am exhausted. So openly, I'd rather be doing these things at lunchtime or at the end of the day, but I can't practice 8 hours in an N95. There is no freaking way I can do that.
Yeah, but I think
Especially
also
with
what's gonna, oh, sorry.
Oh, I was gonna say, if you put a level 3 over it, it's gonna be even more challenging.
worse.
Oh gosh.
Yeah, it's gonna be like climbing Everest or something. No, and what I think is gonna happen is I think after this is over, years down the road, we're gonna, like Lou said, I think we're gonna look back and think, why did we do so many of these post-op visits? Why did we bring patients back? Like, that was insane. Like, why did we waste all this time doing that? It was so, like, the efficacy of just doing it via teledentistry, yeah, with like a smart mirror or like a video camera or whatever. Like, why did we do that? I think we're gonna look back and it'll be one of those things that it'll just be a head scratcher. Like the days before COVID and the days after. Like the silver lining from this is like things will be much easier, you know, and the profession as a whole will advance. And dentists will be able to spend more time doing the things that only the dentist can do, you know, and those are things that we could really do like in our free time afterwards, after hours.
Yeah, and I'll just add one little thing too. In addition to some of this technology that Lou mentioned as well, we have had a lot of exposure to mobile dental photography as well. So that's a huge opportunity there too. You can do a lot of things because essentially the challenge that you have is that you have this dark oral cavity and nobody can get a good picture in there. So the technology has just exploded in terms of solutions for getting good images in the mouth and like illuminating it in a way that we can really have good diagnostic quality images and videos. So that, the technology is really caught up to that.
You guys showed some beautiful images, some beautiful tools actually on your webinar when you presented on teledentistry. So for those of you that are in the audience, I would encourage people to go look at that teledentistry recording. We did post the Midway EDU website in the chat box, so you can go click on that and you can look at all the resources. Tracy and Lou also had some fantastic webinars on really valuable information during this pandemic. I am going to move on to the next question, you guys. This question is for Tracy, and it is on sanitizing N95s for reuse. So you talked about how these can be reused, but you know, how often does this need to be sanitized, and how can we sanitize it? Should we be putting it in a paper bag? Should we be sanitizing it in an oven? Can we autoclave it? You know, these are the types of questions that are coming up.
Probably one of the most feasible plans for sanitizing N95 respirators is because the bug, they say, lives on surfaces for as long as 72 hours. So if you give an employee 5 respirators and they're going to wear 1 respirator today, and when you're done, put it in a paper bag like you suggested, second day, third day, fourth day. And by the time you get to here to wear your fifth mask again, you're multiple days out, and there's a pretty clear margin that your mask should now be safe to use again. You still have to be careful putting them on and taking them off, because when people, I've gotten a lot of phone calls and a lot of feedback, you know, can I spray them down with my intermediate level disinfectants and stuff like that? The problem is you are then inhaling that stuff. So steam sterilization is not approved. Surface disinfectants are not approved. Dry heat sterilization, pretty much nothing that's available in a garden variety dental office that doesn't do huge volumes with a big Steris, you know, hydrogen peroxide vapor sterilizer type thing can be done. So the one option maybe is a 6% hydrogen peroxide solution, and you take your mask and you drown it in it for 30 minutes and then take it out and let it dry. But you can't use ethylene oxide, you can't use surface disinfectants, you can't use dry heat, you can't use sterilization. So probably your best bet is to give people 5 masks, and if not, maybe 4 masks, because if you're working Monday through Thursday, and by the time you get back to wearing mask number 1 again, you know, always marked with the person's name and so on and so forth. But by the time you get back to that mask, then it should be decontaminated. Now, hepatitis B and hepatitis C live on a surface for way longer than 3 days. So again, it's going to be very important that if they're visibly contaminated, then you're going to discard them, but put them in the bag and go ahead and use them. And that's when that second mask may be helpful, may be beneficial, because then you can throw that away. But again, breathing through an N95, it filters 95% of all particulate. And if you wear one forever, dang, you know it. And like you described, Lou. So I'm thinking paper bag. Paper bag's going to probably be one of the best ways.
Okay, thank you. Thank you. I was going to move on to the next question, just in interest of time.
Sure.
The next question is actually for Lou. And the question is, how do we help those patients with dental pain who do have COVID symptoms or are working in high-risk environments, which we already talked about the high-risk environments, but let's mainly focus on those patients that have COVID symptoms, and they're not able to control their pain with antibiotics or over-the-counter pain management. Maybe they do need a tooth extracted or an emergency root canal. What are your thoughts on that?
So I polled, you know, Miles and I were talking before this meeting, and I polled the Catapult members, and of the 50 members in Catapult, 40 responded, and all 40 said they would not treat this patient in their office. And then pre-discussion with Tracy, we're not supposed to be treating these patients. So if we can refer them to a place with the proper ventilation, negative pressure, et cetera, that's what I would do. Otherwise, I feel my heart goes out to these people, but some of our guys would put them on tramadol, alternating with Tylenol. I mean, that's really what we can do right now. I mean, we are not meant to be treating these patients. That's the problem. And I'm open to the rest of the panel on this.
Yeah, the risk associated for the practitioners and the staff, it's just, yeah, unfortunate, but it's just too much risk associated.
Mm-hmm.
Thank you.
Agreed.
And I'm going to say, this is why we screen, because we don't want these patients in our office. I mean, if Tracy and I can go dancing around the country, we're going to say screen, screen, screen. I mean, and again, even what the ADA just put out, and I know they're trying, there are much more in-depth questions that we have developed that are on the Midway site. Screening both a week before or 5 days before the appointment and the day before, because things could change the day before. So I can't tell you screening questions and screening when they come in. I can't. It's just where it all fits into place by minimizing this. That's how I look at it.
And honestly, this telephone triage and screening is going to be your friend as it relates to measles, to influenza, to all these other airborne diseases that have always been problematic. And I'm grateful to see that this pre-screening is going to become a big part of everyone's practice, because I get calls about measles and son of a gun, everyone's in a state of panic, you know, so it's good. It's a great outcome out of all of this.
And I want to say, when I read that people are saying, well, treat everybody like they have COVID, okay, that's not what our goal is. Not to treat everybody like they've got COVID. Our goal is to not treat COVID patients. Our goal is to screen and keep them out of the office until their symptoms disappear. That's the best thing I can say. And if you have an emergency patient with a broken tooth and they come in with COVID and you treat them, I'm sorry, you're just jeopardizing your entire team, everybody, and all the patients before and after. It's just not the right thing to do.
No, I 100% agree with what everyone is saying on this panel. I am going to move on to the next question. We've got about 4 minutes left. So what I'm going to do is leave it with, this is the next question for the cones. Is it expensive to implement teledentistry in my practice? So back to, you know, we've been kind of talking about teledentistry.
So is it, no, with an asterisk next to it. Okay, so you could, again, many people, what they're doing now is they're using some of these free apps that are these non-public facing apps like FaceTime on their phone or WhatsApp. You know, there's plenty of different ways to communicate with people that are free by all intents and purposes, right? They're free. However, what we're seeing in a lot of these social media forums are people complaining that, hey, I did a WhatsApp call with my patient, I did a teledentistry, I submitted it to Delta Dental or Aetna or whoever it was, and they won't reimburse it because there's no evidence of documentation. I can't claim that I did a WhatsApp phone call with my patient now, you know?
Yeah.
And so they're submitting that, and there's no real way to validate that you did this, you know, teledentistry consult. So yeah, there's ways to do it on the cheap. Also, there's also other ramifications of using some of these apps, right? They're sort of in that gray area of how safe and secure is that patient data really, right? So now if you take a look at it, there's all these companies are coming out, and that's the great thing about our capitalist market, right? The more competition that comes out, the more that these companies need to kind of compete with each other, and you know, sometimes that can be a race to the bottom where they're lowering their prices so much that it becomes, you know, almost free. But you know, for example, and I'm not advocating this, but I'm saying Henry Schein, for example, has a platform, and I don't use this platform, but I think it's $50 one-time fee, and then every teledentistry consult you do is $4. So if you have 1,000 patients coming into your office a month, you know, that would be a lot of money. But I mean, if you're getting reimbursed for that because all of the information is there and there's patient forms and it's secure and you know you have a place to store the documents, then I guess it could be, I guess, expensive. It's very relative, if that makes sense. So yeah, you could do it for free. You know, some of these applications cost upwards of, you know, $300, but if you get 1 or 2 patients in that you're doing teledentistry consults for, then it kind of pays for itself. So I think that it could be relatively inexpensive if you want to do it like that.
And I will just add as well, you know, like all of these platforms and ways that you can do teledentistry, they're not all created equal, right? Like you kind of get what you're paying for. So a lot of the higher end, you know, on the higher spectrum of the cost, those platforms provide you with an immense amount of security. They have, some of them actually are practice management software that are built in there. It makes it really easy to document. A lot of them have consent forms. They've thought out the entire standard operating procedures. They can basically guide you through the protocol, so you don't have to figure that out on your own. So it really just depends like on how much you think you're going to utilize it, how much value you add to it, and then you need to decide what's going to be right for your practice. And doing it kind of on the cheap could have some ramifications in terms of liability and such. So we don't advocate for that. There's definitely best practices in terms of that, but it could be done really on a kind of like the lower end of the price scale as well.
Thank you very, very much. That actually I wish we had more time to continue talking about all of these topics surrounding PPE, masks, treating COVID, teledentistry, but we are actually at the hour. We are at 1 o'clock, and I do want to respect everybody's time. I want to thank everybody so much for attending this town hall. I want to thank our panelists especially for your expertise, and I'm hoping that we can bring you back in the future to continue this discussion, because there's a lot of questions that we still we haven't even gotten to, and I was trying to be we had the timer going too, but we had some really good discussions today. As the pandemic evolves, I know so will your questions, and so please continue to submit those questions to Midway Education, or education@midwaydental.com. We will continue to monitor our inbox and have more town halls surrounding these questions. I'm sorry if we didn't get to your question today, but we will eventually get there. There's just hundreds and hundreds of questions, and I know that Tracy, Cornelia, Miles, and Lou are also bombarded with all of these questions. And so we will get to those. You know, some great resources are on our webpage at midwayedu.com. So if you haven't taken a look at that, I would highly encourage you to take a look at that webpage. Again, thank you so much to our panelists for today. And we appreciate your support of Midway Education. And we hope everyone has a great day and continues to stay healthy. Thank you.
Thank you.
All right.
Thank you. See ya.
Yeah, bye.